What is Levodopa Carbidopa? A 65-year-old man comes to the office due to progressive difficulty with walking for the past year. In addition, the patient has difficulty lifting her right leg to get into and out of a car, getting dressed using the right arm, turning over in bed, and peeling vegetables, especially with the right hand. Examination shows lack of facial expression, cogwheel rigidity in all extremities, a shuffling gait, and a fine resting tremor of the right hand. In addition to levodopa, carbidopa is also started mainly to reduce the severity of the adverse effects of levodopa. Anxiety and agitation is most likely to persist, despite adding carbidopa to the patient's treatment regimen. This patient with cogwheel rigidity, masked facies, and asymmetric hand tremor has Parkinson's disease, which is caused by degeneration of the dopaminergic neurons in the substantia nigra, leading to a progressive deficiency of dopamine available to inhibit the basal ganglia. Direct dopamine replacement is impossible because dopamine cannot cross the blood-brain barrier. However, levodopa, dopamine's immediate precursor, does cross the blood-brain barrier, where it is taken up by nigrostriatal neurons and converted to therapeutic dopamine by dopa decarboxylase in the brain. In the peripheral tissues, levodopa is rapidly metabolized to dopamine via dopa decarboxylase and 3-O-methyldopa via catechol O-methyltransferase. Excessive peripheral dopamine can lead to unpleasant adverse effects. For example, nausea, vomiting, tachyarrhythmias, and postural hypotension. Carbidopa blocks dopa decarboxylase and therefore prevents peripheral conversion of levodopa to dopamine. In addition to increasing the amount of dopamine available to the brain, carbidopa also decreases many of the unpleasant adverse effects that occur due to the peripheral effects of dopamine. However, anxiety and agitation are central effects of dopamine, so carbidopa does not prevent them. Anxiety and agitation can actually be increased with the use of carbidopa because more dopamine is available to the brain. Hot flashes and postural hypotension seem to result from the peripheral conversion of levodopa to dopamine, so a peripheral decarboxylase inhibitor would decrease these problems. When levodopa is used without carbidopa, more peripheral dopamine is produced. The increased dopamine can stimulate the emetic center, that is area post-trema, because despite its brainstem location, it is uniquely outside the blood-brain barrier. Therefore, by reducing peripheral dopamine, carbidopa reduces nausea and vomiting from levodopa. Tachyarrhythmias such as ventricular extrasystoles and atrial fibrillation are attributed to the increased peripheral formation of catecholamines. Adding a peripheral decarboxylase inhibitor reduces the amount of dopamine available to form catecholamines, so it clinically decreases the risk for tachyarrhythmias. Adding carbidopa can reduce most of the peripheral adverse effects of levodopa. However, the central effects of dopamine, for example, anxiety, agitation, behavioral changes, from levodopa can worsen with the addition of carbidopa, because more dopamine becomes available in the brain.